So actually, it's a very short talk, so I will not talk. My subject today is the endoscopic gastroenterostomy, but we talked a lot about it before. So I will concentrate the talk maybe for 5 minutes about our new technique, which we developed here, called through-stent enterography-assisted endoscopic gastroenterostomy. We call it the TSE technique, and we send it already to endoscopy, 35 cases. If we have luck, it will be published soon. So I will start with small introduction. Can you see the presentation, right?
Yes, very clear.
Okay, so we know that endoscopic or endosonographic guided gastroenterostomy is the indication is gastric outlet obstruction. Maybe it is extended now, the indications. So we are making more now delayed gastric emptying, like gastroparesis. We are doing this technique. We did till now like 8 cases, and they are doing fine. It's still experimental, of course. So I'm not saying that it is an indication, but we are experimenting with it to see if it is really helpful or not. So we all know that the management of gastric outlet obstruction. So we have surgical treatment, which bypass procedure, stenting, or other methods like balloon dilatation, gastric juice extraction or decompression of the stomach. And we have the endoscopic treatment, which was before nodes, which didn't work well. Magnetic compression also didn't work well. And the cutting edge technique and the most promising technique is the endosonographic guided gastroenterostomy. I will not go in details in the literature, which do the comparison between surgical gastroenterostomy versus stenting, surgical gastroenterostomy versus endosonographic guided gastroenterostomy. The conclusion of all of these studies that, as I said, that the endosonographic guided gastroenterostomy is very promising because it had the benefits or the advantages from surgery and the advantages from stenting, and it avoids the disadvantages of both. So the technique developed after Ben Miller invented this lumen opposing metal stent, namely hot axial stent. As we can see here, it has a cautery tip, which we use to puncture the lumen, and then the stent has this dumbbell shape, which can oppose 2 lumens against each other. Here, the stent, I think most of us are familiar with it. So we puncture. First, we deploy the proximal flange, and then we deploy the distal flange. Here is a 3D model. The stent comes out from the endoscope. It penetrates with cauterization through the wall. Either you will do gastroenterostomy or cystic drainage. And then the second step will be releasing the inner flange or the distal flange. And then we release the proximal one. It's a very elegant technique. And I would say the learning curve is not very difficult to learn. If we will do it under observation 5 to 6 times, it would be, I would say it'd be fine. So there are different techniques how you can do endoscopic gastroenterostomy, like direct puncture, which is the techniques we used to do. They developed other methods like inflated balloon catheter, that they put a balloon in the small bowel beyond the stricture, and then they inflate it with water, and they will use it as a target to do the gastroenterostomy or to release the stent, exactly as you do with cystic drainage. Small bowel distension with diffuse water filling, and there's something called EPAS or double balloon assisted bypass, where you put 2 balloons in the small bowel, as we see here in the last picture at the right, and in between the 2 balloons, you will fill the small bowel with water. All of these trials are they try to make the technique more safe and easier. we found that the direct puncture with filling the small bowel with fluid was the best technique, but it still has some disadvantages. We will talk about it later. And there's the last technique, which is called the two endoscopes, where one endoscope will be in the small bowel and the endosonography will be in the stomach, and they will try to do rendezvous, which is really time consuming and needs a lot of equipment. So I will talk now about the direct puncture, which, as I said, it's the most favorable technique in the literature and from our side. First of all, we need to access the jejunum beyond the stricture. So we will put a nasobiliary catheter using a gastroscope. We put a nasogastric tube in the small bowel. Then we will remove the gastroscope and we will leave the nasobiliary tube inside. Then we will fill the small bowel with water, blue dye. As we can see here, here's the nasogastric tube and the small bowel is filled with water and blue dye. Then we will go inside with endosonography and we'll try to identify the filled jejunal loop. Then, to make sure that this is the right loop, that it is not very distal, we will puncture it with a needle to aspirate blue dye. If the blue dye is coming, then we will know that we are in the right loop. And then we will puncture, we will remove the needle, and then we will puncture directly without putting a wire with hot axial stent. This is a video after the puncture with hot axial stent. This is the small bowel here. So the stent is being deployed now. This is the inner flancher. And the proximal one will be released in the stomach. At the beginning, we used to do the balloon dilatation immediately after putting the stent. But we had this experience, and there are many case reports of stent dislocation after balloon dilatation. So we avoid it now. We don't do it anymore, this balloon dilatation. Of course, it's nice. It allows you to come immediately in the small bowel, but leaving the hot axius in place, leaving for 2 days, usually it will take its maximum diameter. So that one was 15 millimeter, but we are using now the new hot axius with 20 millimeters diameter, which is very good for gastric emptying. The complications, of course, the gastroenterostomy is still causing fear for many doctors not to go for it. And why? Because the small bowel is very mobile. It moves itself the whole time. Second, when you puncture with the hot axial stent, you give electricity and then you lose the vision. There is a few seconds when you don't see anything. Afterwards, you see the stent inside a black area. You're not sure if you're in a small bowel or not. And that will cause misdeployment of the stent in many cases. So in the literature is something between 10 to 15%, you'll have misdeployment. But in comparison to other complications in endoscopy, when you do this, you have a perforation in the peritoneum or perforation in the colon, where you perforated the two small bowel loops. And that's why this technique is still scary. As I said, they developed many techniques to try to avoid this, but they are time consuming. They need special instruments, and the learning curve is, I would say, it's very also time consuming. It will take time to learn. That's why, to avoid this, we developed this technique, through scope enterography technique. And that's how we do it. And I said we did it till now in 35 cases. So exactly like the direct puncture technique, we put the wire in the small bowel. Then over the wire, now we are with the gastroscope. We will put the nasogastric tube. As we can see here, here's the scope, the gastroscope. This is the wire. Over the wire, we will place the nasogastric tube. Then we remove the gastroscope. And this is very important, this video, because we also want to avoid to puncture with a needle, because we don't need the needle. We confirm the right loop with two signs. First of all, I have to see the nasogastric tube inside the small bowel. And the second sign that makes me sure that this is the right loop, to see this turbulence of fluid. When my assistants give the fluid or inject the fluid, we see here this turbulence. Then I'm quite sure this is the right loop. I don't need to puncture it with the needle. I don't need to do this confirmation with the needle. After this, this is the hot axius. And my dream was always, and I talked with Boston many times, why I can't inject something through the hot axius. They said we can't develop this. But I noted that there is an opening, a small opening in the tip of the stent, which you used to put a wire, a jug wire. So I tried once with this blue cannula, and it fit inside. So this channel from the wire, we insert this cannula, and through this cannula, you can inject contrast metal after the puncture. So now here the small bowel filled with water. Here's my hot axius at the left upper corner. Of course, we give Buscopan to remove the motility. And now, as you can see, you see this? It's when you puncture, you lose visibility. It's not that bad in this video, but sometimes it's really bad. You are not sure where you are. And here will come this technique through stent enterography to give contrast metal through the hot axius to have a very nice enterogram. If you see this, then you are right. Everything is safe. If you don't see this, don't worry. Just take the stent back. This puncture you did with the hot axius is not a problem. And I'm talking about, I saw many cases where many colleagues punctured more than 3 times with hot axius. Even it goes in the bowel. Just give antibiotics and conservative therapy will be enough. But your target is to reach this view. If you have this, then everything is safe. So we give the contrast metal. 1 second. Yes, here is a video. It's very bad quality because I took it with my smartphone. This is here, the hot axius is inside. And then the contrast metal will be injected. We will see it live now. And it is fine. This is small bowel. And make sure that you are at least 2 centimeters to 2 centimeters inside the small bowel. Then you are allowed to deploy your stent. Here the internal flange. You take it back, make a gentle traction on the small bowel, and then deploy the proximal one in the stomach. Here. So immediately you will see the contrast metal you injected is coming in the stomach, which is a good sign. And you can exchange to upper endoscopy and have a look at the small bowel without dilating anything. Just to see this. You can also inject some blue dye through the nasobiliary tract tube, and you will see it coming out, which will confirm your diagnosis. And this is the barium meal afterwards. And we can see that the dye is coming very quickly in the small bowel. And the patient is happy and he can eat in 2 days. So that's it. That's the small presentation about this technique, which I believe is very promising. And it's not only for the gastroenterostomy. I would recommend it also for cystic drainage, or whenever you need to use hot axius, use through the stent contrast metal injection. With our 35 cases, clinical success, technical success was 100%. In 2 cases, we noticed with the through the stent enterography that we are outside the small bowel, so we retracted the stent and nothing happened, and we succeeded with the second puncture. So I hope that would be useful for many of my colleagues. Thank you very much.
So thank you very much. A very simple but very useful technique. My question, can you, instead of injecting dye in this cannula, can you aspirate and notice that the methylene blue is there instead of injecting uregram? If you aspirate through this cannula, you are injecting through the nasogastric tube methylene blue. So if the methylene blue come to you, then you are in the right place.
I didn't try it, to be honest, because I mean the cannula is not fitting well in the wire place, so it's not very tight. I don't know if I will apply negative pressure if I can aspirate something or not. Second, the lumen I think is very narrow to aspirate, and actually it is always a hectic time after you puncture with the hot axius. You don't need to lose any second. So I find just injecting this contrast metal is very fine, and there is no hazards of it, even if it will come in the peritoneum.
Okay. Any question?
I want to ask a question about the type of cannula you introduce inside the hot axis stent.
This is the blue cannula, the smallest one. The smallest one.
About caliber 0.
I think 23 G, something
23?
like this. Yes.
Okay, 23. Okay.
Dr. Mohamed, thanks for this elegant presentation. I want to ask about another change in the maneuver. What about the injection while we are injecting in the jejunal loop, which we are looking to target? We inject saline dye, and also we can inject contrast and also follow fluoroscope guide plus EUS guide. Because
the fluoroscopy is 2D, and you are not sure if you puncture with your hot axius, you'll not be sure that you are in the right loop. So that was at the beginning. I used to inject through the nasobiliary dye with the blue and things like this. But if you are parallel to it, which can happen, and it will happen, you will not notice it because you will lose the vision during the cauterization, and you will be in black area. Believe me, you will believe that you are in small bowel, but you are not. Everything will look fine under fluoroscopy, but still it's a 2D image. You can still parallel to the small bowel, and it will look exactly as you are inside the small bowel. That's why if you are inside and you inject the contrast metal and you have the enterogram, this is for me it is the best safety method to be sure that I'm inside.
Okay, thanks.
You're welcome.
Thank you for a nice demonstration. I would like to ask a question about identification of the jejunal loop, because there is some cases reported of inadvertent puncture of the colon.
Mm-hmm.
So how you make sure that you are in the jejunum, in the right place?
Yes. First of all, we have to differentiate between two things. One of the complications that you will have the colon in between, which is different. So there are people who are puncturing in the colon.
Interposition, colonic interposition.
Yes, this is bad, of course, but that needs endosonographic experience. So I would say any good endosonographer, if he will do good assessment, he can exclude that there's organ in between the stomach and the small bowel.
So if there is any signs that you can to be able to be sure that you are in the jejunum, a sure sign.
A sure sign that I'm inside the jejunum is to give the contrast metal and I have the enterogram. This is for me the surest sign. That means I'm not in the colon and I am inside the small bowel. Okay. But to make sure that you don't have colon in between the small bowel and the stomach, this is endosonographic image.
Yeah, okay. Thank you so much.
You're welcome.
Thank you very much, Dr. Mohamed Abdel Hafiez. We are always happy and honored to have your new innovations. So simple, but very useful. Thank you.
It's my honor. It's my honor, Dr. Hussein. Thank you very much.
Shukran.
I will leave now. Thank you very much because I have to work. Thank you for the invitation and wish you all the success.
Thank you. Thank you very much for your generous cooperation. Thank you very much.
The honor is mine. Bye-bye.